Dear viewers, welcome to the second Straumann live session here at the EAO Conference 2019 in Lisbon. As yesterday, we've got an exciting guest today here with us in the studio, and I'm very proud to introduce Professor Ed Bedrossian. Ed, you've been contributing a lot on the treatment of edentulous patients with implants. You've been contributing to the scientific literature and specifically also to treatment recommendations. You are a professor at the University of the Pacific in San Francisco, and you're also a director of the implant training program, and you're also maintaining private practice. So Ed, it's a big honor, it's a big pleasure. Thank you very much for joining us here on stage.
Thank you very much. It's my pleasure to be here in Lisbon and have the opportunity to share some of my experience with my colleagues here. And thank you for hosting me, and thank you for having me here today.
Thank you. So my name is Michel Malaun. I'm head of the clinical operations team at the Straumann headquarters in Basel in Switzerland, and I'm very happy to be your host again. So Ed, mind if we speak a little bit about edentulous patients? You have plenty of experience, but can you tell us a little bit how it started for you? When did you treat patients with these immediate treatment protocols for the first time?
Well, I think the immediate concept we started maybe in the mid-90s, but prior to that, we were obviously following the two-stage delayed loading principles of osseointegration that was well established by that time. Our motivation for immediate implant placement began what I call in the anterior zone with what I call preservation is more predictable than reconstruction.
Yeah.
So taking out anterior teeth and immediately placing an implant without surgical flaps, without allowing the hard and soft tissues to collapse was the motivation. It turned out to be a sound, scientifically based idea, and then we slowly progressed to posterior single teeth, partially edentulous cases, and eventually immediate loading full arch cases.
So is there somebody who has actually inspired you in the beginning? Is there a master that you have learned from?
Obviously, it's P.I. Brannemark, and his entire focus of education was that patient-centered. So the patient is paramount, and everything we do has to be evidence-based and well documented, because taking care of our patients is why we're here and why we learn.
Mm-hmm. So can you elaborate a little bit more on immediate concepts? Because, you know, just the word of immediacy has different aspects about it.
Yeah, that's a great point. I think immediacy, for me at least, has three meanings. One is the immediate implant placement, for example, single tooth. The second is the immediate provisionalization of that single implant case. And then thirdly, the fully edentulous patient, whether it's the terminal dentition patient or the existing edentulous patient. So immediacy for me has those three different categories and procedures, if you will.
Right. So interestingly, of course, with you having so much experience, you also start seeing patients that have had these restorations for quite some time. So when you look at these patients that are coming back and have received their restorations like 10 years ago or even before that, what do you see? Are these patients still satisfied with their solution?
I think so. We actually, at our residency program, have published at least 3 articles on the lifestyle change, the satisfaction, the impact that immediate reconstruction has had on patients, especially the terminal dentition patient who's never experienced having a removable prosthesis. Mm-hmm. It's one thing to be edentulous wearing a denture and now having a fixed prosthesis. It's a totally different ballgame when you have teeth. Mm-hmm. And you've never experienced a denture, and by virtue of having the treatment of the immediate loading, you are exempt from that unpleasant experience. So our follow-ups on quality of life, speech, self-esteem, psychological impact has been extremely positive. Patients as early as 1 year post-op and as far out as 15-year follow-ups.
Mm-hmm. Because, you know, I always imagined it quite challenging for a patient, let's say, that who had perio conditions before, who just, you know, had challenges to actually keep their teeth maintained, and now they're going into such a big treatment. They do get teeth, but of course these teeth need maintenance as well. So can you elaborate a little bit on how you educate these patients and what you're doing so that they can keep their reconstruction for as long as possible?
Yes, I think it's a very logical concern to see a patient who has periodontal disease throughout their entire mouth, and you are thinking now, how is this patient going to maintain this bimaxillary reconstruction? My experience has been that the practitioner has to be very diligent in their education of the patient as to why they, not necessarily worry about why they got there, but how not to get there again with the implants. Educating them on oral hygiene, educating them on the maintenance and the recalls that they have to do. Patients have suffered with their current condition, so they're actually motivated to and very happy to have a second chance at reestablishing their function, because not only it's eating, but it's socializing. It's spending 90% of the day being confident that their teeth are not moving, that their lips are supported. So there's a huge motivation factor for these patients. And then obviously they have to be compliant. You can tell them as much as you want, but you also have to spend the time to make sure they heard what you said, they understood it, and then they maintain their follow-ups. And usually this kind of patients do very well.
So speaking about patient conditions, I think that's a very important point. One point is the compliance, as you have mentioned, but at the same time, different patients having different conditions to start with. You have been doing a lot on recommendations on treatment protocols regarding the number of implants and how to position the implants. Can you just, in a few words, summarize these treatment protocols, the most important ones that you are using currently?
Yes, I think when we talk about the cliche evidence-based, what does that really mean? What that means to me is if you have authorities that are not related to each other over a long period of time, such as 20, 25 years, describe the same biomechanical principles. They are not related to each other, they're not from the same university. That kind of biomechanical principles that are consistent between Skalak, Bohrangert, Brunsky is basically the evidence. And if we follow the simple rules, but they're dogmatic rules, our distribution of the implants, the number of implants that are placed, end up being very, very predictable in this group of patients. But we have to follow them without skipping steps.
Right. The biomechanics is one part. Sometimes you just have a patient where you probably, I can imagine, would like to insert the implants in a certain position, but you just can't because there's no bone available. So you may have, or you may consider other options, and you've done a lot.
Exactly. I mean, we started off with grafting procedures, and then this concept of graftless approach has now become the contemporary approach. And if you look at the statistics, the graftless approach has a much better predictability as compared to grafting cases that I used to do, 30 years ago. Identifying the deficiencies, for example, in the maxilla, how large is the sinus, how much bone is available, and then modifying the tilted implants or the zygoma implant and distributing the implant along the arch form and having a rigid cross-arch splinting has proven in the last 20 years to be an extremely well-documented and predictable procedure. So in conferences like this, being able to discuss the various treatment options, again, the biomechanics are exactly the same, but we are tilting implants one way or the other based on the available bone. But as long as the biomechanics and rules are followed, the outcome is the same, no matter which approach you take.
Right. So you are, in your private practice, committing actually to the Straumann Pro Arch concept, which is our system of treating edentulous patients. Can you elaborate a little bit on that, on how this compares to other systems?
I can. I'm very delighted to join the Straumann family and adopt the BLX implant primarily as a surgeon because of the uniform single platform they have. As surgeons, we are placing our implants, as we talked about, in a certain distribution. There is no way for us to know the quality of the bone until we're in there. You may treatment plan with a 3.75 millimeter implant, and you may not get the insertion torque you want. So you go to the 4.5, you may not get it there. You go to the 5.5, but now you are worried in using other systems that angulated abutments may not be available. So having one platform for all the different surgical widths of implant takes the stress completely off the surgeon and allows them to do their proper surgical treatment, achieve the proper insertion torque, and have an implant that could be restored by their colleagues without any problems. So the BLX has been especially revolutionary. I don't think there's any other system that gives you that leeway.
So besides the prosthetic platform that you've mentioned, the BLX implant is our newest implant, and it addresses, from our point of view, a gap that we weren't able to address before with our current stream implant portfolio. So can you tell us a little bit about your experience with the BLX implant?
I think just like P.I. Brandemark's work started with bone biology, we're really talking about bone biology. And BLX fits the entire scientific documentation, which is the most traumatizing thing we can do to a bone is to cut it. So the central core of the BLX is very narrow. So the osteotomy that's made is quite small. And then the expansion or the condensation of the bone by the thread design, which gets progressively larger and progressively thicker, so that osteoconduction, the compression, is kinder to bone. So we are able to stabilize an implant with the smallest osteotomy or smallest trauma and get a very nice stable implant because of the configuration of the threads. So again, a very well thought out, scientifically based morphology or composition of the implant.
Just out of curiosity, we've been speaking now a lot about these immediate treatment concepts. Are you ever using delayed concepts, and when do you consider that?
Well, honestly, in the last 20 years, I have not. Let me elaborate a little bit more. Two-stage versus one-stage, delayed versus immediate. So two-stage, where you place the implant and you covered it up and then uncovered it later, I have stopped that for at least 20, 25 years. Every implant gets a abutment. I generally will immediate load only full arch cases. And that's primarily because the cross-arch splinting that you can achieve by full arch. But every other single teeth or partially edentulous case, I may provisionalize it. I always provisionalize the anterior cases because of aesthetics, but they're out of occlusion. So they immediately provisionalized. So immediate implant, immediate provisionalization, immediate load. The immediate load, I particularly myself reserve it for the full arch, cross-arch splinted cases only.
So I can only assume this is based on the patient's request to leave your dental office with a tooth or with teeth, or?
Yes, and maybe that's a little pet peeve of mine. I think our job as clinicians is to present what we would do for ourselves. A cardiac surgeon doesn't ask you, would you like 2 or 3 stents? They tell you what you should really have, what they recommend. So when I see a patient, especially a terminal dentition patient, I think of myself and I recommend them to have the immediate load, immediate implant placement concept. And then I think it's just up to the practitioner to be skillful, not only in the technical, but also the knowledge of how to apply this concept. And to go back to your earlier question, I can't remember the last delayed full arch case I have done. Every single one is immediate load. It can sound a little bit crazy to say every single one, but they are. My mindset is from the first drill to understand what kind of a bone I'm dealing with from experience, and then appropriately undersize and choose the implant so the patient will walk out with a fixed prosthesis, because that's how I would want to be treated.
So attractive to the patient was also attractive to the clinician. So if somebody starts as a clinician being interested in these immediate treatment concepts, what do you think is most important to consider as I wouldn't say as a beginner, but probably as somebody who has some experience in dental implantology?
Yeah, I think we should not shy away from the term inexperience, because if you have not done a certain procedure many times, you are inexperienced in that procedure. So I think the first thing in any type of a case is treatment planning. Understanding the fundamentals of dentistry and treatment planning and oral rehabilitation. And then everything starts with the end in mind, so the final prosthetic design, then and then can that be actually created by the laboratory technician, and then the surgery. So we have to think with the end in mind and then begin with the end first, which is the surgery. Our colleagues who are, including myself, went into surgery because we didn't want to think about prosthetics. Well, implant dentistry brings us all back, and the team, the restorative, the surgeon, and the lab have to be all on board and know each other's business.
Okay. So, Ed, I think we have already quite progressed in time. I would like to take the chance also to send a few inviting words to the corporate forum where you are going to present later today. So what is the topic, and what are the highlights that you're going to speak about?
Sure. At 5 p.m. I have the pleasure of presenting 4 versus 6 implants, basically showing the summary of the biomechanics and treatment planning protocols that we discussed. So I invite everybody at EAO to come and attend, and hopefully there's something we can share and we can learn from each other.
Okay, I will be there for sure. So let me tell you, thank you very much for coming. I enjoyed this conversation a lot, and I'm really looking forward to the presentation afterwards.
So did I. Thank you very much for having me.
So, dear viewers, this has been the second Straumann Live session here from the EAO 2019 Congress in Lisbon. I enjoyed the session much, and I'm also looking forward to the third and unfortunately the last session tomorrow. But for the time being, let me just say, muito obrigado, as we say in Switzerland, and see you back tomorrow. Bye and take care.